Welcome to my domain modeling video presentation. The topic of my model is computerized diagnosis of lung cancer. The reason I choose lung cancer as my healthcare topic is currently lung cancer is the second most common cancer, and by far it is the leading cause of cancer death. This table shows the estimated new cases and the deaths of cancers by site in United States this year. Lung cancer ranks the second in the new cases and the first in the death. The most important prognostic is 5-year survival rate. This figure shows the 5-year survival rates of 5 most common cancers. Compared to the other 4 types of cancers, lung cancer has the lowest survival rate. The reason that lung cancer ends in such a low survival rate is only 16% of cases are at early stage when diagnosed with lung cancer, marked as localized in the left figure. And also, the 5-year survival rate of early stage cases is much higher than the other stages. But the fact is, 57% of cases are at advanced stage when diagnosed with lung cancer, marked as distant in the left figure. And advanced or distant stage means cancer has metastasized to remote organs and not curable. The 5-year survival rate of advanced stage is only 4.7%. The reason that most cases are diagnosed at distant stage is lungs have very few pain receptors, so they don't typically process pain. Usually, symptoms of lung cancer don't appear until the disease has already spread to the others, and the symptoms may include persistent cough, chest pain, voice change, and etc. Even if lung cancer does cause symptoms, many people may mistake them for other problems, such as an infection or long-term effects from smoking. This may delay the diagnosis. Actually, lung cancer can be detected early. Screening is the use of tests or exams to find the disease in people who do not have symptoms. Studies have verified that low-dose CT scan in people at higher risk of getting lung cancer can help find abnormal areas before symptoms appear, such as the nodes in the figures we choose there. We can find nodes inside the lung. The earlier diagnosis, the lower risk of dying from lung cancer. This can be achieved by implementing computer-aided diagnosis to help physicians in 2 ways, which are 2 major objectives of this model. First, distinct the higher risk people, and the second, detect nodes for early-stage lung cancer. This is my domain structure, which explains 4 aspects of lung cancer. First, lung cancer have 2 major categories, which are non-small cell lung cancer and small cell lung cancer. Non-small cell lung cancer is most often diagnosed than small cell. The second aspect is the symptoms for lung cancer. As I mentioned in previous slides, early symptoms do not usually occur. The third aspect is risk factors of lung cancer. The most significant risk factor is smoking, either current smokers or former smokers. Also, people who do not smoke can be high-risk people as well, such as people live with smokers and suffer from secondhand smoke, or people exposed to substances like random during the work, or people whose parents or other family members has been diagnosed with lung cancer. The last aspect is the screening to find lung cancer, including non-invasive tests as yearly tests or invasive tests as further confirmation. This is my model structure. It consists of 3 major parts. The first part is knowledge base. The second part is the inference engine, and the third part is the user interface. I will go through them in detail. The first part, knowledge base. It consists of compiled information in various forms, such as if-then rules or logistic equations. And this knowledge base is not static, it is dynamically changing. When the system accepts new data is added into EMR or hospital information system by user interface. The data could be numerical data, natural language data, or image data, like a CT scan image. The database keeps being updated every now and then. New data can be used to refine our decision support model. The second part is the inference engine. It accepts values of predictors and fits them into the formulas, together with rules and associations from the knowledge base. Then the results can be returned to the user interface and used by the decision makers. It is like the CPU of a laptop processing the calculation. The third part is the user interface. It is the main communication mechanism where decision makers and the clinical users interact with our model. The communication can be separated into two parts, one for decision makers and the other one for clinical users. For decision makers, they obtain personal information from individuals, including risk factors and the symptoms, and pass them into the model to see whether this person belongs to high-risk people or not, and recommend him to take screening. After adding screening data into the diagnosis model, such as node detection, decision makers can predict the possibility of malignant and arrange surgery or treatment. For clinical users who perform screenings for individuals, such as CT scans or biopsies, they take the lab results and put into the system. As most of the lab results are generated by computers, the data entry process can be automatically done by the system to prevent data error caused by manual input. This decision support system can be applied to a current medical system and benefit in several ways. First, GPs can recommend high-risk people to get yearly skin screening or further confirmation tests to suspicious lung cancer patients. Second, physicians can utilize the system to predict the probability of malignant and benign and adjust the treatment plan. Third, radiologists read the radiographs empirically, and the detection of nodes relies on personal judgment. The decision model can assist the reading process with the whole database containing all radiograph cases. Also clinical administrators benefit as well because people used to review radiographs by multiple radiologists to ensure accuracy. The audit procedures require more clinical staff. Computerized detection system can play a role of multiple radiologists, and also it helps new radiologists to perform readings. The limitations of this model is very obvious. First, to avoid misdiagnosis, we want high sensitivity. This will lead to false positives, which need radiologists to check manually. Also, if we want to make the system more accurate and increase specificity, it will lead to false negatives and misdiagnosis. Second, the nodes smaller than 5 mm can be detected, but it usually requires re-examinations after a certain amount of time. The third limitation is refining the node detection is very hard. Normally, an image will be segmented into pixels and return several parameters, such as color, intensity, age, and texture. Most of them cannot be measured and refined by human. Therefore, refining the node detection is very hard. And this is all for my domain modeling video presentation, and this is the references I used during the presentation. Thank you.